All right, well, hello everyone. Today is our DC&R Journal Club debate session titled Approaches to Low Rectal Cancer, Abdominal versus Transanal. This follows the successful inaugural debate that we held last year, which was titled CONOS is the Answer, which is available on the YouTube channel. Thank you all for tuning in or watching it later. As always, I'm very grateful for such an excellent Journal Club team. There's lots of tireless work behind the scenes, particularly by Maggie and Stephen. We are, of course, ultimately guided by Dr. Galandiak, who's the DC&R editor-in-chief, and we appreciate her supervision. This is our disclaimer. We encourage the audience to comment and ask questions via the chat. We'll try to address that and hopefully have quite a good discussion on chat as well whilst the presentations are going. So the aim of this debate is to have a robust discussion about the pros and cons of the different approaches to the surgical management of low rectal cancer. We have two teams, both having three speakers. We'll explore the merits in adopting either an abdominal or a transanal approach to the TME. Each set of speakers will have an impartial judge involved in the discussion. I guess it's important to note that the world of rectal cancer is rapidly changing. There are numerous medical therapies which show promise, and of course will augment the surgical approach to the disease. However, the focus of our debate today is particularly on the operative options. The speakers have been provided with the main questions ahead of time. After the main questions, we have a lightning round, which are three clinical scenarios which the participants will answer as they see fit. So for the main questions, as you can see here, the first speaker will have 4 minutes to state the argument, the opposing speaker will have 1 minute for rebuttal, and then 4 minutes for their arguments, and then there'll be a 1 minute rebuttal. And then each judge will ask one follow-up question for each of the speakers. To ensure the fairness of the debate, we will flag when the speaker is coming close to time, and then at the conclusion of their allotted time, the microphone will be turned off. Next slide. Just a brief discussion about TME. Of course, this is not for the speakers and the judges, but for some of the audience. The optimal surgical approach in dealing with a low rectal cancer has polarized colorectal surgeons, and there are proponents for open, laparoscopic, robotic, and transanal technique. And I guess the only thing uniting all these proponents is the need for a total mesorectal excision, the history of which starts in 1908 when Sir Miles of St Mark's Hospital in London observed that following a proctectomy for rectal cancer, patients died from recurrent disease, and a significant proportion of the recurrences were present at the site of the remaining mesorectum, therefore highlighting the importance of removal of the entire mesorectum. And then in 1982, Bill Heald advanced on these concepts and re-emphasized the importance of meticulous dissection, popularizing the term holy plane, and his efforts led to the era of improved outcomes in rectal cancer care and standardization of technique around the world. So the key principles for rectal cancer surgery, of course, is the removal of cancer en bloc with its fascial envelope, and therefore achieving a wide circumferential resection margin, and for patients with low rectal cancer, also, of course, removing the entire TME and ensuring a complete distal resection margin. A tradition of sorts, a poll to start, and so would like the audience to just answer what their preference in the operative approach to low rectal cancer is, and in the end of the debate, when Dr. Galandiak has a concluding speech, he will reveal the answers. Thank you. All right, next slide, please. So it gives me great pleasure to introduce our debaters and judges. Some of them, of course, were kind enough to host prior Journal Club sessions in their institutions, and those recordings are available as well on the YouTube channel. And unfortunately, they all have an incredible list of achievements, and so in the interest of time, I'll provide just a very brief summary. So on the affirmative side, we have Dr. Siller. She is a professor of surgery at Mount Sinai Hospital and serves as system chief of colorectal surgery. She published the first case report of TATME in 2009 with Antonio Lacey. Dr. Siller is, of course, the leading investigator in the North American phase 2 multi-center trial of TATME for rectal cancer. The second speaker is Dr. Makel. He is a professor of surgery and chief of the Division of Colon and Rectal Surgery in UMass Memorial Medical Center. His research interests include innovative surgical approaches to colon and rectal diseases, including both TAMIS and TATME. The third speaker is Dr. Caicedo Marulanda. He is the current assistant chief of colorectal surgery at Orlando Health in Florida and the medical director of Orlando Health Colon and Rectal Institute, and has previously pioneered transanal surgery in Canada. Now we have the opposing team. The first speaker is Dr. Liska, who is the section chief of oncology at the Department of Colorectal Surgery at the Cleveland Clinic, and is the director of hereditary colorectal neoplasia and Cleveland Clinic Young Onset Colorectal Cancer Center. Speaker 2 is Dr. Matt Albert. He is the medical director for surgical innovation at the Digestive Health and Surgical Institute at Advent Health. He is, of course, the inventor of the TAMIS procedure and has created the first FDA-approved flexible transanal platform with Applied Medical. Our third speaker is Dr. Langenfeld. He is a professor of surgery and chief of the Division of Colon and Rectal Surgery at the University of Nebraska Medical Center. He is also the lead author of the 2023 ASCRS CPG Addendum on rectal cancer. Next slide, please. Now, we are fortunate to have three incredible judges, and we are truly privileged as they are all past presidents of ASCRS. Dr. Fleshman is the professor of surgery at Baylor University Medical Center and is the member of the medical executive board there. He is also, of course, the first author of the Z6051 lap versus open resection of stage 2 or 3 rectal cancer trial. Dr. Hyman is professor of surgery and chief of the section of colon and rectal surgery at the University of Chicago. He is the director of the American Board of Colon and Rectal Surgery, an associate editor of the Annals of Surgery and Journal of Gastrointestinal Surgery. Dr. Connor Delaney is the executive vice president of Cleveland Clinic and president of Cleveland Clinic, Florida. He is a past president of the ASCRS Association, of course, but also the International Society of Laparoscopic Colorectal Surgery and the Midwest Surgical Association. Dr. Delaney has published 17 books and more than 420 manuscripts. Next slide, please. So now we come to our first question. And the question is, there is an oncological benefit in the TATME approach for low rectal cancer surgery. And Dr. Silla will speak first, and Dr. Liska will follow.
Thank you. Can I have my slides, please? There is just so much data in support of TATME. I just cannot do it verbally without some support here. So yes, there is a benefit. Next slide, please. So just for those of you who don't really understand TATME, next slide, please. Animation should play. But the bottom line is that this bottom-up approach can be done for the entire dissection of the TME, especially for difficult narrow male pelvis. Next slide, please. Or it can be combined with your abdominal approach, whether it's laparoscopic, open, or robotic. The bottom line is that you'll use a TATME approach to do the most difficult part of the operation, which is a distal mesorectum, to be able to improve the quality of your dissection and reduce the risk of positive distal and circumferential margin. Next slide, please. So TATME has not evolved in a vacuum. It has been 16 years in the making through the ideal framework from swine models all the way to experimental models, moving to animal model cadavers. And then now we're in that really precious phase of having short and long-term results coming from very large prospective observational trials, multi-center trials. And now the 2023 was a very good year. We've actually had the two first randomized controlled trials comparing TATME to laparoscopic TME in large cohorts. We'll go over this. Next slide, please. So this is a lot of data, and this is important to show that data as it evolved. I'm only focusing on the large series, more than 100 patients, and you can see that overall, across the world, in both single institutional and multi-center trials, you've seen really quite good TME quality, ranging all the way to 100%, on average 95 to 100% across the board, including the large TATME registry with over 2,800 patients. In terms of the circumferential radial margin, same thing. Remember, the ECOSOG trial had shown a laparoscopic CRM positive rate of 12.1%. So this should be your reference point. So look at the CRM rate, essentially well under 7%, with the exception of two outlier centers with 12.1%. We'll talk about the Norway study. but for the most part, including in the TNTME registry, really quite low CRM positivity. And this is, again, capturing the surgeon's learning curve. Same thing with the distal margin positivity. And most importantly, you can see the two randomized control trials that have been published in 2023, really showing here 50 versus 55 TATME, small, but very powerful, showing excellent oncologic results in terms of short-term oncologic results with a CRM positivity of only 2.4% versus 0% in a TATME cohort. And then the large Chinese trial showing very low CRM rates as well, 0.9%. And Justin Makel will talk about the conversion rates in those randomized trials. Next slide, please. And most importantly, the long-term oncologic results are starting to emerge now. We have now some of those studies have reached 2 to 3 year reporting time point. And you can see here, local recurrence rate mostly quite reassuring, well under 8%, with the exception again of the Norway study that I'm sure we'll talk about at length. But in a Netherlands study that only studied the results from a handful of surgeons, but for the most part, well under 7%. You can see the TATME registry, 4.8% local recurrence at 2 years, which also compares favorably with the long-term results of the ECOSOG Z6051 trial. The randomized clinical trial from Spain also showed very acceptable local recurrence rate, only 1.8% with TATME compared to laparoscopic TME was 6.1%. This is already giving you a hint of the possibility that actually may be associated with better results because of better quality of the specimens. Next slide, please. So this has prompted a revision of the recommendation from the ASC or SCPG guidelines. You can see that just a few years ago, it was still considered to be controversial because of the lack of evidence. You can see here. And now Sean Langerfeld has just led this tremendous work and review of all that data, including these two randomized controlled trials. And now the conclusion is, compared to laparoscopic and robotic TME, transanal TME for mid and low rectal cancer has similar overall complication rates and functional outcomes. That includes oncologic results, just to be clear. And this is a conditional recommendation based on moderate quality of evidence. Very interesting that they loop in robotic TME, since robotic TME, as we know, there's not a whole lot of long-term oncologic results, clearly a sign of bias, but we'll discuss this during our discussion. Next slide, please. So I think this is really important. What's emerging, though, from some of the meta-analyses that are just recently published, this is one from 2021. Please pay attention. This is a network meta-analysis, 30 randomized controlled trials.
Dr. Sella, we have to call time.
And you can see here, clearly, there's a suggestion that TME has a lower incidence of CRM positivity than laparoscopic TME. Next slide, please.
We have to call the time. Dr. Sella.
Oh, my goodness.
I know. I didn't give you 30 seconds. I apologize.
Thank you. No problem.
I'd be happy for Dr. Silla to get more slide from my standpoint.
No worries.
I know. We have to keep on the clock.
To go through.
All right. Okay. Ready, Dr. Liska?
Sure. Thanks. So next slide, please. So, Dr. Silla just spoke about CRM positivity being very low, and we all feel like we get a nice specimen out when we operate and we're all happy. So why worry? Next slide, please. And we were among early adapters for TATME, and we were very impressed by the dissection. It's a beautiful dissection, nice technology. But then slowly with time, all these warning signs came out. And Dr. Silla mentioned the Norwegian study, so we'll talk about that because that really is what caused a lot of concern internationally as well. Next slide, please. So this is the Norwegian study, and these were surgeons that were trained and proctored in TATME. All patients were required to be enrolled in a prospective registry, and they compared it to the very well-established registry. Next. So this is the data, and it's very a stark contrast. And if you look at the regular registry, the NCCR, and looking at an actual true oncologic outcome, which is local recurrence, right? This is an outcome that we care about. And, maybe what's more impressive than just the curves is the type of recurrences. And that's what I want to focus on here, because this is just one trial compared to many, many more that Dr. Silla showed. But the type of recurrences were different from the recurrences that we've seen before. A lot of multifocal recurrences that were no longer sort of candidates for curative intent resection after that. Next slide, please. And here a picture really says more than 1,000 words. The type of recurrences, again, this is just one trial, with data, but what it comes to show, to me at least, what the message was, is that perhaps TATME can lead to different outcomes, different type of outcomes that we have not seen before with laparoscopic, robotic, or open approaches. And we might not know why, but there's some question about the pneumorectum that we do, or the purse string, the distal purse string. Maybe there's something different about this dissection that leads to a different type of local recurrences. Next slide, please. So, we had the same thing. History maybe doesn't repeat itself, but it does rhyme. And we had the same concern when we started with laparoscopic surgery. There was all this concern about port site recurrences. And, history has shown that that really isn't the case. Next slide, please. But what have we learned from history? So I think, it's great that Dr. Fleshman is a judge here. We have the ACOSOC trial, the a la carte trial, where we had prior data from thousands of patients, much more than we have for TATME, but still a rigorous multi-centered randomized control trial was necessary. You need expert surgeons. And what we found that when comparing a pathologic composite outcome, again, based on CRM and TME and TACNIS, we saw that actually laparoscopic surgery was not non-inferior. Okay. However, when we then completed long-term outcomes, we found that local recurrence and disease-free survival were similar. And the immediate surgical specimen quality is not a perfect proxy for long-term oncologic outcomes. And that's something very important to keep in mind. Next slide, please. So what do we learn from history? Go back one again, please. Yeah. So this is a sticker I saw on the hard hats from people at construction sites and in airports. When it comes to safety, we can't take any shortcuts. And that's true in the operating room when we operate on our patients, but it's also true when we do research and when we introduce new technology. You have to do the right amount of work that's necessary to prove that a new technology is safe and, in fact, equivalent or better to previous technology. Next slide. So this is another network analysis, a little bit more meta-analysis, a little bit more recent. So in 2023, comparing all the different modalities we have for low rectal cancer. And here you can see when you look at CRM or this is on the right panel here, they're all similar. When you look at sort of TME antagonist and CRM, when you actually look at, they did this surface under the cumulative ranking curve, and they ranked them for CRM. Robotic was first, then open, then lap, then TATME. More importantly, though, when you look at the actual 3-year disease-free survival and 5 years disease survival for TATME, there just isn't enough available data right now. Next slide, please. This is the same ideal framework that Dr. Silla shared. And I'm really, I admire Dr. Silla for all the work she has done so far. She's, pioneered it. And not only that, but gone through the steps of actually making sure that this is good technology. And the thing is, we're in this step 3. We're just getting the randomized controlled trial started. So we need to see where these come. Next slide, please. So
and you have 30 seconds.
Yeah, again, next slide, randomized controlled trial really are what's going to show us. So in terms of the overall question, is there an oncological benefit to the TME approach for rectal cancer? So how do we define oncological benefit? So we've learned from history, in order to know oncological benefit, you need to look at overall survival, disease-free survival, local recurrence patterns, and we need sufficient follow-up time. So at this point, I think it's very clear that it's very nice. We have a lot of evidence in the making, but currently there's no evidence yet to show that it's better than our current technology.
All right, Dr. Silla, you'll have 1 minute rebuttal.
Yes, I think these are all fair argument, and clearly we were extremely concerned about these pelvic site recurrences, and we've gone through the very tedious process of research, of looking at this very closely. It has not been replicated in other large multi-center trials, as you've seen. It has not been replicated in the randomized controlled trials published from Spain and from China. And most importantly, in our North American series, so 100 patients prospectively enrolled in a trial, including 11 centers in the US and Canada, we have not seen that either. As a matter of fact, our CRM rate positive rate was only 1.5%, distal margin rate was only 1.5%, and actually 67% of our tumors were below 6 centimeters from the anal verge. We had 54% of our tumors underwent a primary hand-sewn anastomosis, and 33% of our patients had a BMI higher than 30. So these were difficult, low pelvic, low tumors in 70% males. And again, we did not see any of those. So the CRM positivity rate being so low, conversion rate being so low, and Justin will talk about this, and the excellent, at least early oncologic outcomes should translate in better long-term oncologic results. And we'll see that very soon.
Thank you very much, both. Wonderful presentations. If I can ask Dr. Fleshman to ask a question to each of the speakers, perhaps if you can start with Dr. Silla first.
Well, I may take the prerogative of the judge to ask them both the same question. One of the things that we dealt with in ACOSOG Z6051 was the level of the tumor and defining that level of the tumor. I noticed on several of your slides that the tumor goes anywhere from 5 centimeters above the anal verge to 10 centimeters. Those are widely different in terms of the impact of the technique. And how would you modify that technique to deal with something at 5 centimeters above the verge, at the level of the puborectalis sling, well below the anterior peritoneal reflection, and someone who you think should be able to tolerate a coloanal anastomosis? What are you doing different? And can you trust what you're doing to give the patient a good outcome?
That's actually a really good question. Thank you for this.
Start your time now.
Okay, thank you. It was really interesting for the phase 2 North American trial. We essentially told the surgeons they could do TATME for tumors up to 10 centimeters. Turns out that the majority of the cancers were actually located, again, 67% of our tumors were 6 centimeters and lower. These already tell you what TATME is, the sweet spot of TATME, which is really the low tumors that are abutting the top of the anorectal ring. Of course, you could go higher, but there's no use for it. We find that actually the best approach is to start abdominally and essentially go below the peritoneal reflection until things get really difficult. And at that point, this is when you switch to the transanal approach to do the distal most difficult part of the TME. Then you combine forces in place and then do either stapled anastomosis or hands-on anastomosis. So this decision usually can be made preoperatively at MDT because you actually, with your finger location, with the MRI and the assessment of the TATME surgeon in collaboration with the abdominal surgeon, that decision is usually pretty accurately made.
Dr. Liska, if you'd like to start.
So, I think right now we have 3 modalities, in terms of laparoscopic, robotic, and open that have all sort of proven where they are in terms of oncologic outcomes, in terms of very low local recurrence rates, regardless, obviously the lower the tumor is, the higher the risk of local recurrence. And that's probably related to the difficulty of the dissection and difficulty of obtaining a clean specimen, but not necessarily, as we have seen from ACOSOG and from other trials, that, TME intactness does not necessarily correlate with local recurrence rates. So I think, we just need to wait those great randomized controlled trials that are in the process of enrolling patients. I think we need to wait to see what the data shows in terms of local recurrence rates. And, having some trials that show some local recurrences that are atypical and that we haven't seen before is just, a warning sign that we really need to wait for that data to mature.
Thank you all. Let's move on to the next question now. The question number 2 is, the TATME approach to the lower rectum is technically easier and safer to perform. Now, if we can have Dr. Makel to start, please.
Great. So we opted not to use slides. So to start, I will be frank. A low anterior resection is not an easy operation, nor is it necessarily safe in inexperienced hands. There are limitations to open and minimally invasive approaches. Across the United States, fewer than 10% of proctectomies are done minimally invasively, and the vast majority of rectal cancer surgery results in a permanent colostomy, even for those tumors without sphincter involvement. Operative technique is critical, as highlighted by Professor Heald in the 1980s as he traveled the world teaching the total mesorectal excision technique, documenting the benefits related to sphincter preservation and oncologic outcomes. TATME represents a surgical innovation that provides solutions to the limitations of open and minimally invasive abdominal surgery by providing inline, high-definition access to the low pelvis. There's no need to retract adjacent structures. The distal margin beyond the tumor can be specifically defined. The TME dissection planes are identified and followed into the abdominal cavity, and the sphincters can be preserved to facilitate a coloanal anastomosis. This innovative approach is particularly beneficial for the most challenging cases: distal third tumors, obese patients, males, and patients treated with neoadjuvant chemoradiotherapy, including TNT. All new procedures should be introduced following the ideal framework previously described, a systematic methodology that begins with didactic and hands-on training, as well as case observation and proctorship and mentorship. This allows surgeons to learn and avoid the potential pitfalls of a new operation. Over the past decade, 20 meta-analyses have documented safety, efficacy, and perioperative and oncologic outcomes comparable and at times superior to trans-abdominal surgery. TATME is easier and safer than transabdominal surgery due to several factors. Number one, simultaneous operating in two fields saves times and stress in the operating room. The extra manpower of an abdominal team is offset by not needing an experienced transanal assistant, just a camera holder. Just imagine being the abdominal surgeon who helps the transanal surgeon who does not have to do any of the dissection below the level of the peritoneal reflection. Number two, division of the rectum and colon and anastomosis creation. There's no TA or contour stapler to maneuver to the pelvic floor, hoping you have an adequate distal margin. And even worse, laparoscopic staplers have not been engineered to angulate at 90 degrees and do not fit in the pelvis to divide the rectum completely. This results in angulated and crossing staple lines that have been shown to result in higher leak rates. Construction of the colon anal anastomosis utilizing a double purse string, single staple technique may facilitate reconnection and results in lower leak rates. Dr. Spinelli has popularized this technique, highlighted in a 2023 surgery publication that looked at 185 single-stapled and 458 double-stapled anastomoses, showing the 90-day anastomotic leak rate was significantly lower in the single-staple group, 6.5 versus 15%. Number three, low conversion rate. Despite enrolling the most challenging cases, most TATME studies publish a low conversion rate of 2%, a clear advantage over other minimally invasive techniques. The well-known ROLAR study demonstrated a lap robotic conversion rate of 10%. The recent 2023 Spanish RCT showed a conversion rate of 20% in the laparoscopic TME group compared to 2% in the TATME group. Number four, finally, Dr. Albert will surely describe procedure-specific complications, but they are extremely rare and avoidable. The Lorick and Ostrich registries published CO2 embolism rates of 0.4%. Urethral injury, considered the Achilles heel of this operation, is as low as 0 to 2% in published series. Most experts agree that the complications associated with TATME are a direct result of the learning curve and untrained and inexperienced surgeons taking on an operation they should not be attempting. Similar to the findings of Dr. Heald, as he taught surgeons the TME technique in the 1980s, where local recurrence rates were routinely as high as 30%.
That is your time. All right, Dr. Albert, if you have queued up for 5 minutes.
Well, there he used my name in that. Hey, restart the clock. 5 more seconds on. All right, very good, Justin. No doubt rectal cancer surgery is really challenging. And although laparoscopic and minimally invasive surgery, the learning curve for these is not simple. It's been standardized over the years, step by step, and made very standardized. In addition, though, it's always predicated on the same approach every single time from above, the same anatomy that we've all learned, the same complex pelvic anatomy that we've all learned. And so when we switch to a perineal approach, in fact, you're adding significant variations to an already difficult operation, which is a recipe to significantly increase challenges, increase learning curves, and complications. Just placing a gel point, we know, has some learning curve to that. And in addition, requires newer insufflators, and in some cases, even 2 insufflators that increase challenges. The anastomosis, because you're left with an open cuff at the very end of it, it even created new learning challenges in this. And in fact, there's even a learning curve associated with the anastomosis. On the other hand, although the distal margin, I'm a fan is and still think is the best utilization of TATME, the fact is it's the most complicated part, requiring a laparoscopically placed purse string perfectly in the rectum that closes the rectal tube completely prior to you transecting that. This is a skill set that was never really learned by colorectal surgeons unless you perform laparoscopic intracorporeal anastomosis. And so, as you know, we trained several hundred surgeons to do this technique. And in fact, more than 80% of them couldn't complete this single step, which is the very first step in the operation, but it's also the most important step needed to be successful and safe during it. When you look at learning curves, a QSUM analysis or cumulative summation curves are used, and usually these are endpoints that you choose and plot out based on things that are successful outcomes of the surgery. A decrease in operative time, a decrease in serious complications. These are all endpoints that we use. And so in our early studies with consecutive 100 cases, we saw that actually it took more than 51 cases to become proficient at this when our operative times went down and complications went down. When you look at other trials in Italy, it was 71 cases. But more importantly, even when we look at other outcomes related to this, and in fact, there's a meta-analysis in Spain which shows that robotic surgery actually has a much longer learning curve than TATME. However, TATME was associated with much severe complications of this in the learning curve. Pat described this fantastically: 34 male urethral injuries, 2 ureteral, and 3 bladder, which I don't even know how you necessarily do from below. The most important, that 10% of those patients required permanent urinary diversion. We did a study, a survey study of respondents from our course. More than 350 surgeons were polled. Only 20 responded, but of those 20, there were 5 urethral injuries. We know that was just one of several problems. The next was carbon dioxide embolism, something that's never seen in rectal cancer surgery from an abdominal approach. We published in DC&R 25 of these complications, of which no patients died, but we even had a patient have a cardiac arrest during one of the live TATME courses. And when you look further at learning curves, what if in the learning curve you cause even more severe complications, like you affected this local recurrence? We've known forever that oncologic surgery, if you open the lumen of the bowel with tumor, it's not good. Specifically in rectal cancer surgery, we've always highlighted abdominal perineal resection. And if you injure the rectal tube and cause a perforation, those patients have much worse survival outcomes and increased local recurrence. And so a very nice study recently, how many?
30.
Showed not only that volume affects the TATME and the learning curve also affect much more serious complications, local recurrence. And in the study of expert high volume centers, 6 centers, they showed that the #1 risk factor for local recurrence was experience. And in surgeons' first 10 cases, they had 12.8% local recurrence rate, case 10 through 45%, and it did finally drop above 40 cases. But this is a serious problem when a learning curve and causes such serious complications, is this long in a world of dwindling rectal opportunities, and the volume effect even can affect oncologic.
Right, Dr. Albert, we're calling your time.
Done.
Dr. Makel, you have 1 minute.
Great, Matt. 3 thank yous. #1 for the device, #2 for training me, and #3 for highlighting the failure of implementation, because it's really not a failure of the procedure itself. I mean, the intuitive people would not let us hop on the robot and just start doing cases. There's a training program you have to go through to competency, and that's where we failed. This operation is very challenging. There's a steep learning curve, and we cannot have cowgirl surgeons just start doing them. There has to be a systematic way of training, a systematic way of implementation, and and most people on the call know that can occur when you have a place that has #1, a champion, #2, a team, #3, the foundation skills, #4, the proper volume, #3, the comprehensive training we've outlined, and #6, the capacity to record and report your outcomes. Because at the end of the day, that's really what it's all about, is making sure that you're delivering the safest and most efficacious operation for your patients.
Thank you very much. A fantastic point. Now, can we please get
don't I have one more, don't I have another minute rebuttal?
No. So
that's just the first round.
You had 5 minutes, so 4 minutes of speaking and the
Gotcha.
1 minute of rebuttal baked in.
Gotcha.
Sorry, but we're trying to keep to time. Now, Dr. Hyman, can I get you to ask a question of both participants. Thank you.
Sure. Thank you for those wonderful presentations. And like my colleague, Dr. Fleshman, I'm going to ask you both the same question, and it pertains to this issue of learning curve. So that in this, I'll start with you, Justin, and then Matt, the same for you. In this imaginary, highly selected world where rectal cancer is centralized, like in these trials, where a tiny percentage of surgeons have the volume to do these cases, largely by expanding the indications, tumors for 10 centimeters, especially in a world where many cases are not even being treated with surgery anymore. Surgery is not central. Rectal cancer surgery is not centralized in the United States. So that you've shown that in highly selected hands, these operations can be done safely. But what about the real world? Why aren't you going to make the United States Norway? How many other operations can you've seen where a country has to outlaw an operation because it's done by these people? Will there ever be this training and learning curve? Are we going to knock off a whole generation of patients with rectal cancer?
So I think we have to learn from our European colleagues where they do cohort patients, and there are rectal cancer centers. And there's a reason why for Pat Silla's North American trial, she was only able to recruit 10 different centers to participate because, as I mentioned earlier, you really do have to have those prerequisite baseline foundation skills and the adequate volume in order to commit to learning this technique. And once you've committed to it, then you recognize the benefits for the patients, and you also recognize the potential advantages beyond even just primary rectal cancer. So all TAMIS or transanal types of operations. So I think we have to rely on our societies. So similar to industry, like Intuitive, who has limited access to the robot until surgeons prove proficiency, I think we have to lean on our societies to make sure that these procedures are not just done haphazardly, that everybody goes through a very structured and standardized training protocol so that they are able to perform the operation safely, and that we learn from the mistakes of prior trials.
All right, Dr. Albert.
Well, I'd say that unfortunately, it's the problem and the fallacy of all research that's done in this way, that we spend millions of dollars, and no doubt that all this work shows that in the hands of experts who have been properly trained and well above their learning curve, that this is a good procedure with equivalent outcomes. And that's the problem, the fallacy that it's then generalizable to the rest of the world, because it's not. The study and the outcomes that we performed, all of us are fortunate, all by fortunate surgeons who are well beyond their learning curve, who are experts in rectal cancer, and we see that that's just not the norm. Especially in the United States, where we just don't have a system, that we can't police people, that there's not centers of excellence that occur all over Europe, where this is done in a centralized way. And so I think we'll continue to see this problem in that way. At the end of the day,
that's time. All right.
Thank you all. Now let's move on to question 3. Thank you. The question 3 is adoption of TATME for low rectal cancer enhances the value-based model of surgical care. And we have Dr. Caicedo Marulunda, Dr. Langefeld, and the judge, Dr. Delaney.
Great. Thank you very much for the opportunity. Very grateful to be here. So the question revolves about value-based model for surgical care for TATME. And I think one has to answer how to define value in the management of rectal cancer. Value-based healthcare involves delivering high-quality care with optimal outcomes while considering the cost involved for these type of cases. To assess the impact of TATME and the value-based model for low rectal cancer, I think several aspects need to be definitely considered. The thought initially when it was described by Pat Silla and Antonio Lacey was it will enhance the ability to get access to those rectal cancers. If we all remember, the issue with rectal cancer is an issue of access. It's a cylinder within a cylinder in a rigid cavity. So how to access that? And then patients are very concerned about the ability to preserve their sphincter. But we talk about, some of those different outcomes, especially oncological outcomes. And like every other speaker, I'm pretty sure my colleague, Dr. Langenfeld, who I respect and admire very much, will talk about the Norwegian moratorium, which, by the way, I think is the blueprint of how not to implement any type of high complexity operation. If you look at that paper, the second paper that includes 157 patients, is terrible. It is 157 patients in a 4-year period of time with 7 centers, 3 of which actually dropped very early. So the last were 4 centers that had a maximum volume of 57 cases in those 4 years, which gives you a volume of less than 1 case per month. And then you look at their outcomes in a more granular fashion. For instance, positive margins. They describe having a 13% margin positivity, but they only mentioned circumferential margins being 5.6% or something in that vicinity. What is the rest? The rest is actually distal margins, which defeat by principle the very definition of the operation. It's a very poor technical application of how to do this. Centers with no volume doing this operation, and they're great surgeons, don't get me wrong, they're fantastic surgeons. If you look at the registry, 3.4 local recurrence rate. Now, if we're going to look at other things about volume, we also have to look at, what patients want to have, and one of that is sphincter preservation. We still don't have the data, but patients probably benefit from having this in the most distal aspect, because what is the main challenge? To define that distal margin. That is not something that even robotic surgery, laparoscopic surgery, open surgery can give you certainty with. And I just want to paraphrase my colleague, Dr. Matt Albert, whom I have spent a lot of different courses with. And one of the things that he always says is, lucky those that actually were able to get on board with TTME at the right time. So I truly believe that certainly, as Dr. Hyman mentioned, this is not an operation that could be done in every hospital, and certainly not in every hospital in North America, because rectal cancer is not centralized. But so applies for pancreatic cancer, esophageal cancer. These are very complex operations. And if we want to offer the best value base to our patients, we need to centralize this and do it in a patients that have the ability to have this. Now, there are many other factors that we could include.
30 seconds.
Like infrastructure, the composition of the teams, how reimbursement is going to be. But in the ideal world, having this is simply a tool, another approach that could be used in expert hands to actually customize treatment for those individuals, provide personalized care, which in my mind is actually value-based care for our patients. Thank you.
All right, Dr. Langenfeld, if you're ready.
Yes. All right. So first of all, Antonio made great points. I agree with a lot of them. It's a tool, and it shouldn't be done everywhere. When I envision value-based care in low rectal cancer, I think safe, efficient, effective, and widely applicable. And widely applicable is my big concern with TATME. The big question is, can we train colorectal surgeons in 1 year to go out and perform TATME safely, independently? The published learning curve for TATME from Dr. Albert's group is 50 cases. And I don't think there's any fellows graduating with 50 TATMEs these days. So what I think what's happening is there's a small, highly select group of surgeons that have mastered the technique and have outstanding outcomes. And I applaud them. Most of you guys are on this phone call, but that same group dominates the peer-reviewed literature on the subject, which might lead to underreporting of real-world difficulties with the technique and the resulting complications. So my concern is that real-world outcomes are not as good due to the difficult learning curve and the need for a second colorectal surgeon in the room, which is a big luxury that most surgeons don't have. Complications might be uncommon, as Dr. Mako mentioned, and concentrate on early experience, but when they occur, they're severe, they're life-changing for the patient and the surgeon, and they're likely to scare the average practice surgeon away from completing the learning curve for TATME. People talk about cost a lot when they talk about robotics as being an alternative, and so I think that's a complex topic. I'm not an expert in it, because I think it extends across cost centers, it's longitudinal, but the capital costs of a robot are certainly higher, and that was one big argument for TATME earlier on. But nowadays, pretty much every hospital has decided to buy a robot. And so it's not like they're making this decision about whether or not to invest in a robot. and the money's already spent. The cost is also shared across multiple service lines, such as urology, gynecology, and general surgery. And then at our own program, we're using this thing called the AMP program, which essentially eliminates the need for purchasing multiple robots up front. Instead, you lease the robot, use a charge-per-click approach, and that reduces capital costs as well. And if you look at in-hospital costs, including disposables, there was a 2023 study from Annals of Surgery Open that I found preparing for this talk that showed a higher in-hospital cost for TAA-TME when compared to robotics, but honestly, I think it's probably pretty similar between the two techniques. But there's also the cost for OR time and surgeon time. And so OR times are comparable between the robotic approach to TME and a two-surgeon TAA-TME approach. But this means that TAA-TME requires a second fully functional surgeon in the room. Meanwhile, robotics allows the primary surgeon to have more control over the case, require minimal bedside assistance or expertise. And so that's a big difference there. And then there's cost to the patient. And this is a little bit more difficult to talk about because the peer-reviewed literature is mixed. But I personally need to see more data on the long-term GI, sexual, and urinary function after TAA-TME. Because we're finding out, just as he had already mentioned, patient quality of life is the most important outcome when it comes to rectal cancer surgery. So I have plenty of time left, so I get to tell my personal story with TAA-TME. I went down to Orlando in 2015 and trained with the great Dr. Albert and had tons of heavy hitters in my class with me. I was the only colorectal surgeon at UNMC. I was already proficient with the robot, but it was the older robot. Less versatility, no staplers, no energy devices. So I watched the videos. I observed a case with Dr. Albert. I completed a cadaver lab where the instructors told me that casually that about 20% of paired trainees mobilized the prostate, injured the ureter every time they did a lab. I walked away feeling entirely unprepared to do TAA-TME in independent practice. My junior partner joined me 2 years later. She did about 10 TAA-TMEs in her fellowship. She felt entirely unprepared as well. And so as a result, we've done exactly 0. And this is the same across the board. So the Orlando team, Dr. Albert's team, they did a survey in 2017 looking at 81 graduates of their TAA-TME course. And right when they graduated, 74% were very or extremely comfortable with the technique. 95% said they're going to use them for distal rectal cancers. And then they did another survey post training, and only 50% of them had actually done a TAA-TME. And he already mentioned they had a 25% urethral injury rate, 15% major hemorrhage rate. And so that's just kind of what happens to real world surgeons when they get exposed to the technique. So in summary, like when I come across online discussions of TAA-TME and robotics, which I do a lot because you guys know I love to argue with strangers on Twitter, I try to emphasize these are tools, they're not religions. Despite social media's algorithmic tendency to simplify things into absolutes, this is not a dichotomous black and white comparison. In a perfect world, a surgeon would probably be proficient in both techniques and would select them individually. And ultimately, the value-based advantage of robotics, though, is that it's ubiquitous. Most hospitals performing rectal cancer have multiple consoles. Most surgical residents have extensive experience in the robot when they graduate. It's not limited to colorectal surgery. It's surgical oncology, general surgery, et cetera. And so, they're just getting way more comfortable with that. So basically, people are voting with their feet. Each year, the gap in utilization between robotics and TAA-TME gets bigger. And with these huge disparities, there's going to be a lot more future innovation in the more common technique. And so it's basically just an unwinnable battle for TAA-TME on a practical playing field with practicing surgeons. So I got to side with the winners. I'm sorry.
All right. And 1 minute, a counter rebuttal.
No, I think Sean has great points, absolutely. And this is pretty much, I believe, emphasizing the fact that this is not applicable to every hospital. This is not something that can just be done everywhere. I think this is an operation that is incredibly complex and needs to be implemented carefully and judiciously at very specific sites. And perhaps the idea of developing some sort of a fellowship or a mini fellowship for people that will do this. I don't think people coming out of a 1-year fellowship in a regular colorectal program should be implementing this, by no means. Now, if we're going to talk about cost, I think the cost of setting up a TAA-TME program is significantly lower. We're talking about a $3 million machine, which is the robot, which I do, and I love it. But I don't think is the answer for every single operation. Again, because the problem is access. When I have that problem, even if I'm doing robotically, I can just simply pull that platform. The time is created by Dr. Albert. Just go ahead and detach that 2 last centimeters of the rectum. Any other things that could be argued, but I think my time is up.
Thank you very much for those opinions. Now, if I can get Dr. Delaney to ask a question of both the affirming and opposing teams.
Great. Well, I'll follow along and I'll ask the same question of both. Great evening so far, Vlad, and everyone who's spoken, and Sean and Antonio, nice comments. So I think we've heard a lot about it. It's a useful technique. as long as it's done by somebody who's appropriately trained and experienced and is doing the right volume to stay good and proficient at the technique, because I think those of us who've done it realize it's not necessarily easy. So the question is going to be appropriate case, but I'll dive into that a little more because we don't really yet have the evidence. Yes, we do, and we heard that lovely first debate about circumferential resection margin and Dave talking about, reducing incidence of local recurrence. Well, if you look at the Chinese randomized controlled trial, the circumferential resection margins were equivalent. So we still don't have the evidence to decide where utilization should be. It's not just cost. I think clearly it'll beat a robot for cost, Sean. However you pay for it, it's about $2,500 a case. You can pay up front or you can pay later, but it's about $2,500 a case. So value really is quality over cost. So you've got to be improving quality or reducing cost. And ideally, there's some factor built in there for appropriateness. So my question to you would be, thinking of things like OR time or 2 surgeons or local recurrence rate or positive CRM, if you are trying to prove the value of this for rectal cancer, because now we've maybe 4 arguable platforms for approaching a low rectal cancer in an obese male, what would you use to define value? What's the best one? And it's not an easy question to answer. I don't think we know it for very many surgical operations, but what direction do you think we should be heading in to pick the right metrics to define value?
Yeah, Dr. Casito.
Thank you. Yes, thank you, Dr. Delaney. I think that's a great question. I think, value can not only be defined by one single thing. I think it's a composite of many different things. But more importantly, and I think we all agree, Will and Nicole will agree that what is most important is what really is valuable to patients. Patients are the ones that have to live with either the recurrence, with the incontinence, with whatever things that we do, with the complications that we do. In my mind, the ability to have different tools that could allow you to deliver what patients want, and every patient, I think, will have a clear idea that removing a segment of the rectum will definitely change their lives no matter what. But many patients are really set on the idea, I do not want to have a colostomy. I have had many patients that say, I would rather die before I have colostomy. So a sphincter preservation, keeping the procedure in a minimal invasive fashion, even if it means, we'll just make a small fine still and we still keep the benefits of the MIS dissection. I don't think that's the answer. I think TTME gives you the answer that maybe you can preserve that sphincter and still preserve an MIS approach.
All right, Dr. Langenfeld.
I agree. I think patient quality of life should be the main value, and avoiding colostomy is very, very important to them. The question is whether or not TTME allows this more than the robot. And in my hands, I'm not failing with the robot very often, if that makes sense. You certainly can still release the rectum from below. Tatas. I've done tons of tatas in my life. You don't have to have Dr. Albert's wonderful gel point path from Applied to do that. And so I don't think that that's something that's specific to TTME. I've done plenty of times where you release from below to get your distal margin delivered through the anus and you do your anastomosis hand sewn. So I just don't think that for a lot of us, for the majority of cases, that TTME is necessary in order to achieve, an anastomosis and a negative distal margin.
All right.
Thank you very much for that. Now we're going to move on to the lightning round, which is a clinical question for each of the speakers, and it kind of goes to Dr. Delaney's point of which type of patient is this procedure suited for. So the first question is for the first team, so Dr. Liska and Dr. Silla, who have a fairly straightforward patient, so 58-year-old female with an anterior adenocarcinoma just distal to the peritoneal reflection. She's reasonably sized, has had an abdominal hysterectomy. On endoscopy, the tumor is hemicircumferential anteriorly between inferior and middle rectal valves, and the MRI comments this as being T3N0. Now, what approach would you take? And just to perhaps vary the order, can I have Dr. Liska speaking first and then Dr. Silla to follow?
Sure, thanks, Vlad. So just distal to the peritoneal reflection. So in terms of distance from the anal verge, that generally, depending, this is a female, let's say it's at around 10, 11 centimeters. If you say just distal to the anterior peritoneal reflection, is that the type of cancer you're envisioning here?
Yeah, maybe a little bit more distal, given that it is sort of in terms of where the valves are, but say 9 centimeters, 8 to 10 centimeters, somewhere there.
Sure. So I just saw Dr. Langenfeld's comment. This is a nice cancer that I think, any approach you'll use should be good. Probably not what TATME was designed for. Those difficult tumors that are low down in obese males. So this is someone that I personally would approach generally laparoscopically, sometimes robotically, and I think it would be a very nice dissection, a very nice circumferential resection margin, and a very safe surgery.
Dr. Silla?
I cannot argue, although I would definitely confirm this patient by rigid proctoscopy in the office and confirm, because a lot of times you get this report and it turns out, and that's why the surgeons get in trouble, where it's actually much lower than anticipated and they're starting to struggle. And then this is usually what leads to conversion, 10% lower trial. We haven't seen updates from North American surgeons, lower conversion rates. I know Sean's series is great, but we haven't seen those results in North America. We'd love to see them. We have them for TATME. And so for this patient, I agree, TATME would be overkill. So I would not, unless there's something really a feature, it's lower than anticipated, or is another caveat, I would not plan to do a TATME in this patient.
Thank you for this. If I can have Dr. Fleshman just comment, and also perhaps comment about the debate in its entirety. The reason I picked this case is because we would all agree that this is I guess no cancer is straightforward, but this is one of the more straightforward ones. And when we talk about the learning curve, is that kind of the cancers that you would then do for the learning curve, which is a catch-22?
Well, thank you, Vlad, for putting this on. I appreciate Susan letting us do this debate. I think I've learned some things, and I've also heard some things that concern me. Let's put it in perspective. Notes or natural orifice surgery is not the Holy Grail. When we first started thinking that we could do our operations through the anal canal without an abdominal incision, Dr. Hunt and Much and I did a cadaver study, which showed that you really can't take the splenic flexure nor do a high ligation easily. And so all we're talking about now is the bottom, very bottom of the rectum. You can do a ta-ta procedure with a laparoscopic or a robotic resection without having to do a ta-TME and get the same outcome. The patient gets a coloanal anastomosis. The tumor does not spill because you put a betadine soaked sponge in a closed rectal cuff, and then you finish your operation. The ta-TME shouldn't actually replace it and go digging into the urethra when you can do a ta-ta type operation. So that would be my preference given those circumstances.
Thank you. For the audience, feel free to continue commenting on the chat. Hopefully we'll have a bit more of a discussion about these cases. Next question, please. This is for the second team. So we have the other end of the extreme. We have an obese 45-year-old male who underwent long course chemoradiation with the aim of a TME resection. However, after his clinical response, he disappeared and then presents 12 months later with rectal bleeding and a palpable mass. The mass is just above the anorectal junction, so potentially suitable for a coloanal. It's circumferential, but it is traversable, and roughly say it's 5 to 6 centimeters. CT does not demonstrate any distal disease, and the cancer originally is commented to be T3, maybe T4N1, and then after having 3 months of chemotherapy, he seems to have had a radiological response, and the MRI has been downstaged.
Start with Dr. Albert. Oh, sorry, you're muted, Dr. Albert.
Yep, I got you. When you say obese, how obese?
One Florida unit.
Yeah, this is a patient who I've seen, and I would like to say that Australia is skinnier, but unfortunately, I don't believe that anymore. Quite obese, so BMI of say low 40s, 43 odd.
Yeah. Yeah. So good. I'm assuming now we've moved on from the consideration of the other that we're done with the other treatment, and we're moving on to that he needs surgery for this. So he's 45, and despite his obesity, he likely doesn't have much insight into that and demands sphincter preserving surgery, I'm sure. And so in this patient, though, at the same time, even mobilizing the splenic flexure, which you're going to have to do for this tumor and sphincter preservation, is going to be fairly difficult. So approach-wise, again, low rectal cancer, where I think I always mobilize the flexure, that I would start laparoscopically doing this from above. Generally proceed as much as I could. And I think for a good procedure that he's going to require a transanal approach from both an oncologic standpoint and sphincter preserving standpoint. That I think there's, even with the robot, there is zero way that you're going to more efficiently and nicer come all the way down onto the other side, clear the mesorectum off the pelvic floor, and be able to staple. Where this is a patient with a low tumor that optimally can be is reconstructable, that I would do this transanally.
Dr. Makel, when you're ready.
So so thanks for this example. This is look, this is going to be a difficult operation regardless of how you do it. And we are all colorectal surgeons, and you have to have the entire armamentarium available to you. And this is actually an ideal case for TA-TME. Now, whether it's going to be able to be accomplished that way, it's hard to know, but it is going to give you the best option for, number one, defining that distal margin, and number two, creating an anastomosis. And so I would plan to start the operation transanally. I agree that the operation is going to require significant mobilization from above. And if I can meet the peritoneal cavity from below, I will. If I can't, I'll always have the option to then shift to a laparoscopy from above. And if that's not possible, switch to OPA from above. I think at the end of the day, the goal is to perform a TME, which is intact and gives the patient the best option for diminishing the chances of local recurrence and long-term survival.
Thank you. Dr. Hyman, can you say a few words? Thank you.
Sure, just quickly, I always say there's two things you want to be in surgery. You want to be safe and you want to be clever. And this guy's life's at risk here. And, so one is, I wouldn't assume that he wants to have sphincter salvage. So that's one thing. I think that's why we're doctors. We counsel patients. But I think that a standard TATA would definitely be something that could be done here. I think that's, to me, is a real problem. Is I have no problem with everybody doing, the people who are extremely well trained and have high volumes doing TA-TME, but we seem to have lost among the fellows the ability to do transanal surgery and transanal anastomosis. That's something we can teach. We see this problem with pelvic pouches. We see this problem with rectal cancer. Is we need to make sure that we teach our trainees how to salvage situations like this by understanding how to do anastomoses inside the anus.
Amen.
Thank you for that. Now, our last question for our third team. We have a 78-year-old independent male presenting with tenesmus and weight loss. He is anticoagulated for AF and has moderate renal impairment, but otherwise is systemically well. He has a palpable tumor about 7 centimeters from the anal verge. There is no evidence of metastatic disease. He does, however, have a history of prostate cancer, which was treated with brachytherapy about 8 years prior. His MRI is reported as T3N0. His CT does not demonstrate any distal disease. What would you do? Dr. Langefeld, maybe we can get you to speak first.
Is it MR deficient? Wouldn't that be great if it was? But it's probably not. But check MR status, and then For a patient like this, I'd also talk to the radiation oncologist. I'm pretty thorough and like to get information for them about what's been done and what tools you still have. But for most of these people, if they can't receive more prostate or more pelvic radiation safely, I would probably treat him with neoadjuvant chemotherapy and then restage. And if he's had a proper response, proceed with total mesorectal excision. And for me, it's a robot, but I already admitted to you guys that I don't feel comfortable doing TAT-TME. I'm the common man in this situation. So, but that being said, this would be, a pretty otherwise straightforward operation from that perspective. But I would, feel pretty comfortable with that, especially if I thought I could get a negative margin without giving additional pelvic radiation. Notice I'm going under time. I'm the only one doing that. Everyone so far I've been under time.
I agree. Congratulations. You have been fantastic. So I picked you for my team.
Time to light a cigar. Can we, Antonio, can we have your opinion, please?
Yeah,
and particularly,
sure.
I've put in the brachytherapy as a question to see if that affects TATME in some way mechanically.
Sure. No, that's a great question. That point that I don't think brachytherapy changes the operation itself. I mean, that's a plan that is going to be difficult no matter how we approach it. Now, I would like to know a little bit more about, what the patient's goals of care are for, 78-year-old gentleman that is fully continent, is interested in preserving the sphincter or not. I don't like to leave rectal stumps because I think patients have a miserable life after. I don't think this patient necessarily I will push like he must have a TATME. This is not the case. I think you say, I think you could approach this person either way. 7 centimeters is mid-rectum, below the peritoneal reflection, most likely definitely needs a TMA. So you could do this robotically, you could do this laparoscopically. You're going to have a challenge approaching the anterior plane, no doubt. But reconstruction, I think, is doable either way. I don't think this is the case in which, TMA is necessary as opposed to case 2, in which I believe TMA was a really good thing to have.
Thank you very much for that. Dr. Delaney, can you please say a few words?
Yeah, regarding the case, I agree with the approaches suggested for the other cases. And for this, I guess you'd like to know height and weight before you'd make a final call. But again, I think the comments are on point. Radiation comments on point, and anticoagulation. We all stop anticoagulation all the time for pelvic surgery. It's just another thing we do. My reflection really would just be on along the lines of what Jim and Neil talked about. The most important thing we're trying to do here is a good outcome for the patient. And actually, it reflects back on the conversation we had about value earlier on. So in my mind, it's, the number one most important thing to most patients is cure, followed by recovery, which is your outcome with a low complication rate, and ideally a quicker recovery, but that's less important. It's not about doing it laparoscopically. It's about doing an operation, or pick your device. It's about doing an operation that will give the best chance of cure, overall recovery with a low complication rate. And then it's only after that that you figure in the lower part of that value equation, which is the cost. The upper part has to be optimized first, and that's cost OR people. But great discussion, great points raised, and well done to everybody. Thank you.
Thank you very much for this. So now we'll have the results of the poll and then some closing comments by Dr. Galandiak.
The results of the poll show that 84% of the participants that are watching our debate were comfortable with laparoscopic or robotic surgery, and only 9% were doing TAT-TME, and 6% doing open, and 1% other. So I wonder what the other are. But so it's very interesting. So I think that goes along with some of the comments perhaps of Dr. Albert about the high learning curve, and as well as the comments of Dr. Hyman. And I think no matter what you do, you have to be comfortable with what you're doing. And also what Dr. Langenfeld said, even though he did the course, didn't feel that comfortable doing the procedure. And I think a lot of the series, whether it's from China or wherever, talk about the very significant number of patients that you need to be comfortable or get the learning curve for TAT-TME. And I think we all know that for patients with rectal cancer, your first operation is your chance to really cure the patient. And if you don't do well on that, your patient really doesn't have a good chance. But I want you all to know how incredibly hard Dr. Bolshinsky worked at this debate and how much background work there is to making it successful. So please join me all in thanking him for all his work for this. And thank you all for joining, for all our debaters, and for all the judges. Thank you very much for joining us.
Thank you for the opportunity.
Thanks.
Thank you very much. That was great.
It was lovely.
Well done.
Thank you.
Good night, everyone.
And everybody have very good holidays and a happy new year.
Likewise. Good night, everyone.
Good night.